Welcome and good morning, afternoon, and evening to all. I am Jim Wynn, current president of SOSORT and your virtual host for our Bracing for Adults with Scoliosis webinar. This is SOSORT's fourth webinar, and I'm excited to share that we have maxed out our registration with 500 individuals who will be taking part in our webinar today. So on behalf of SOSORT members, the board of directors, and the Educational Committee, I thank you for your commitment to SOSORT and the advancement of the non-operative management of idiopathic scoliosis and other structural spine changes. I also want to thank Sonia Shriver, SOSORT Secretary, for organizing this event, to all of our speakers, and Tony Betts for his behind-the-scenes work. Our membership dues has allowed us to offer this webinar free of charge. Thank you to all our members who have paid their yearly fee to SOSORT. We ask any SOSORT member that has yet to pay their annual fee to please do so. We want to continue to offer continuing educational opportunities to the medical community, and we are only able to do so if our members are current with their yearly fees. Also, if you are not a member of SOSORT, we encourage you to join our family. In St. Sebastian this year, we asked, who is SOSORT? And the answer is you. You have the opportunity to share your experience, share your knowledge and research, and learn from others in a congenial way. No better way to do that than by submitting an abstract to our next annual meeting, which will take place as part of Spine Week in Melbourne, Australia, May 1st through the 5th in 2023. Abstracts are due by October 15th. This is an incredible opportunity for us to share our expertise, to learn from other professionals from 20 spine-related societies. So you will have the opportunity to interact with members from 20 spine societies, share research ideas and outcomes. Please consider joining SOSORT 2023 as an attendee or presenter. And remember, when registering, identify yourself as representing SOSORT. We have designed our program today to be interactive. Please use the Q&A section to write your questions, not in the chat. Questions in the chat will not be brought up for the panelists. If you see a question that you agree with, just upvote that particular question, so we will know to get to it. We will do our best to answer as many questions as we can today. Our speakers will try to answer you in writing after the seminar, so please do not ask your questions anonymously. We'll begin our webinar looking at the evidence on bracing in adults along with indications and treatment goals, after which we will have a question and answer session. So please be sure to type your questions during their talks in the Q&A area. This will be followed by a roundtable presentation from 3 experts in adult scoliosis brace design and fitting, who will share their clinical approach and decision-making process with questions to follow. It is now my pleasure to introduce our first 2 speakers, both past presidents of SOSORT, Dr. Fabio Zanna and Dr. Jean-Claude Dimero.
Welcome to this lecture about the evidence on bracing for adults with scoliosis. I'm a physiatrist from the ISICO, the Italian Scientific Spine Institute. The main issue about the natural history of scoliosis during adulthood are connected to the progression, back pain, breathing and heart issues, pregnancy, social and psychological impact, and mortality. The main study reporting data on the natural history of scoliosis, of untreated scoliosis, is the Iowa study. This is a long-term cohort study with a follow-up of 40 years presenting the progression rate and 50 years presenting data about the quality of life. The cohort was made of about 100 patients. About mortality, there is not an increased risk of mortality in patients with scoliosis with respect to the other people. About lung function, there is a moderate impact of thoracic scoliosis with larger curves, more than 50 or 70 degrees, on breathing. Usually, this condition is not so relevant in terms of impact on the quality of life. and no severe cases are reported. Heart problems can affect patients with very severe curves with more than 100, 120 degrees, so it's not so frequent. About pregnancy, a recent review stated that minor curve progression often occurred during pregnancy, though its permanence was questioned and significance is unknown. A flexed posture is very common in severe scoliosis that progress. So this is one of the scenarios that we have to avoid with our treatment for our patient, because an unbalanced posture is really impacting on the quality of life of these patients and generating pain. What drives the risk of progression in scoliosis during adulthood? The activity of the curve is very relevant. Curves below 30 degrees, there is a risk in curves larger than 30 degrees and a higher risk of progression in curves larger than 50. This is true for the thoracic curves, and it's true also for lumbar curves. About thoracolumbar curves, data are available just for 10 patients, so the conclusions are very, very weak. Also for double curves, we know that the risk is present. Edgar and Mehta showed that the risk of progression is correlated to the size of the curve and also to the localization, with lumbar curves having a higher risk than thoracic curves. Marty Pumara defined in a slightly different way curves during adulthood, considering type A and type B. Type A are idiopathic scoliosis that progress during adulthood. You can see in the blue. And the progression is slower than type B, which usually start with a smaller size but are much more aggressive. Here we have a comparison of type A and type B curves according to the data by Marty Pumara. Type A are idiopathic scoliosis, usually diagnosed earlier, as we can see from the graph on the table. And usually at the beginning, at the first discovery, the size of the curve was already larger, and the mean cobangle at the moment of the first lateral subluxation is much, much higher. Type B are degenerative scoliosis, usually diagnosed later during the life, and the mean age is higher at the first subluxation moment, and also the cobangle is lower. What about patients that have been treated? Because the data presented so far are about the natural history of untreated scoliosis. Well, we can say that there is a very interesting study by Lange and colleagues. It's very interesting to notice that there is no difference between juvenile scoliosis and adolescent idiopathic scoliosis. There is a slight progression over time for both of them. The difference in terms of rate of progression is the size of the curve at the end of treatment. If we compare major curves larger than 45 degrees, the red line, we can see that we have a significant progression, while minor curves smaller than 45 degrees have a similar trend to the one of the operated curves. You can see the green and the black lines. Also, this paper by Edgar and Mehta shows that the progression during adulthood is really correlated to the curve size at the end of growth, with larger curves being much more aggressive with respect to the lower ones. For sure is one of the main problems in scoliosis patients. It's more frequent, even if usually it's not that intense as it can be in other conditions like, for example, a disc herniation. The sagittal balance is very important as a risk factor for this kind of pain, much more than the coronal imbalance, which is connected to the progression but not so much with pain. It was documented in many papers and can be seen in everyday clinical practice. The type of pain of this patient is usually a persistent pain, especially when they stand too much, when they walk too much, typically at the apex of the curve or eventually on the other side. And sometimes it can radiate to can be connected to a traction on the roots, on the nerve roots, but can be also connected to trigger points. About the treatment, the conservative treatment, which is the evidence today? At the beginning of 2020, a systematic review about bracing for scoliosis was produced and published. 10 studies were included, 4 was just case reports and 6 were cohort studies. The braces included were soft braces in 2 studies and 8 included rigid braces. For a total of 339 patients, they were mainly females, and in many studies they were just females. Various types of scoliosis were included. There were different outcomes. Some were about pain, some about function, and others considered the progression in terms of Cobb angles. The follow-up time was really different from different studies, ranging from 2 days, from some case reports, to 17 years. The brace wear prescription ranged from 2 to 23 hours per day, and the compliance was quite mixed. Most studies report modest to significant reduction in pain and improvement in function and quality of life at follow-up. There were mixed findings also with regard to Cobb angle changes, and the participants from one study noted some discomfort associated with bracing. The overall conclusion of the authors was that even there is a high risk of bias, there is very low quality evidence in favor of bracing for scoliosis patients. This paper by Palazzo and Marti Pumarà and colleagues presents the results of a nighttime bracing for adults with scoliosis. They applied a light brace to their patients, which was custom-made and modeled in order to be well-fitting but not corrective, as you can see from the picture. And the aim was just to give some support without any aim in being corrective. Minimum of 10 years follow-up before the starting of bracing and 5 years after the beginning of bracing. And this means that finally they had a population of 38 patients. And another requirement was to have 3 X-rays before and 3 X-rays after the treatment. And what they found is that the rate of progression dramatically changed. It was reduced, as we can see from the numbers here, degenerative, but also to idiopathic scoliosis. We can see this also graphically. Each line is a single patient. As we can see, the progression rate was ranging, but was quite fast, especially in degenerative scoliosis. And after the starting of treatment, there was a reduction of the progression rate in the most of the cases. Not in all the cases, some continued progressing, but there is a trend toward the reduction, a slowing of the progression. This is another study, a pilot study, aimed at presenting the results at short term of a new brace fabricated, which is called the PIC brace patients. We included 20 females with scoliosis, both degenerative and idiopathic. They had on average 65 degrees of Cobb angle for the main curve, and they was prescribed 2 to 4 hours per day of bracing. Some of them were already doing some exercises, others not. And what we measured was the pain and quality of life after 1 month and after 6 months. As we can see, there was a significant improvement in pain, both worst pain, back pain, and leg pain, that was maintained over time from 1 month, which is T1, to 6 months, which is T2. About the quality of life, we didn't notice any change as measured by the Oswestry Disability Index and the COMI. So in conclusion, scoliosis is not a life-threatening condition, but can affect the quality of life of patients. Progression and respiratory problems are correlated to the curved sides, while back pain is correlated mainly to the sagittal alignment. There is evidence that specific scoliosis exercises and bracing can help improving pain, quality of life, and slowing or reverting the progression rates. Thank you for your attention and happy to take your questions and comments.
While classical scoliosis braces essentially use modulation of the growth plate, in adulthood, the brace acts on the soft tissues. To simplify this presentation, we have grouped the major types of braces according to their indications in terms of biomechanical goals. The latest technological developments make it possible to achieve more ambitious objectives with the realization of corrective braces also for adults. The first type of brace is intended for scoliosis at the end of bone growth when bone mass has not reached its maximum. The brace acts on the soft tissue. To be effective, the correction must be greater than 50%, and the plastic deformation is maintained by the initial full time. The 3-point systems are effective on single curves. Another characteristic feature of adult scoliosis is pain. The flexible or slightly rigid brace limits the extreme amplitudes of the spine that are always painful, and the stresses on the pathological anatomical structures. There is no risk of muscular atrophy as long as the patient continues to lead a normal life. These braces do not modify the progression of scoliosis. The progression risk is often associated with an imbalance of the spine in the frontal plane. Correction of frontal imbalance requires molding in the corrected position in a frame, stabilizing the pelvis and scapular girdle. The brace is bivalve with lateral overlap to maintain frontal correction. For the first time to our knowledge, a French retrospective study of these braces was done with more than 20 years of follow-up. The results suggest that underarm bracing may be effective in slowing down the rate of progression in adult scoliosis. These braces are made after a corrective cast for a minimum of 3 weeks and worn an average of 6 hours a day. Here, a brace with sternal support for a thoracolumbar curve. The lateral cut is not vertical, but anterior at the pelvis level for better stability and to avoid shearing effects. The posterior valve can be used alone, for example, in a car. Sternoclavicular supports are often poorly supported in adulthood. They also have the disadvantage of limiting bracing ampliation. Tolerance is then improved by the use of a low-density polyethylene, which unfortunately is less corrective. We specially studied in a clinical audit 158 consecutive patients with a minimum of 5-year follow-up extracted from our prospective database. The great number of patients and an average 8 years follow-up allows to study the radiological progression of polyethylene bracing for adult scoliosis. Stability or improvement of more than 5 degrees in 80% of cases justify rigid bracing in adults, especially since in the majority of cases, the painful instability was accompanied by a progression of the angulation. The average age of treatment is 56 years, and the average initial angulation is 40 degrees. Males are less numerous than the distribution of adult scoliosis. There is no relationship between stability and initial gob angulation. While frontal imbalances could be stabilized, sagittal imbalances were not stabilized with polyethylene bracing. The actuation of the distance C7 plumb line is the only negative element, and that's why we currently use for some patients another technology. The prognosis of scoliosis in adulthood depends more on the sagittal plane than the frontal plane. Rigidity in the sagittal plane can be provided by the metallic bar of the lion brace. The book-like opening of the brace facilitates the brace fitting in adults. The rigidity is less in the frontal plane, with the two lateral hemivalves in polyamide of 3 mm thickness. The corrective position is derived from the lion-Swede coupled movements in the frontal and sagittal plane. Digital cast has replaced the traditional plaster cast. The sagittal plane and the frontal plane are corrected simultaneously, taking care of the global balance of the spine. In the frontal plane, the correction includes translation along the vertical axis and global rebalancing of the occipital axis. At the level of the left lumbar convexity, the iliac plateau contributes to the translation of the vertebral bodies along the median line, especially for convex imbalance. In the sagittal plane, two actions are essential: lumbar lordosis and global rebalancing of the sagittal occipital axis with high upper breast support, which give a larger lever arm. The latest review of this year analyzed 12 relevant publications. Conclusions are that there was no objective criteria and clear indications for bracing, and no consensus concerning the prescription of braces, daily wearing time, and duration of the intervention for patients with adult scoliosis. The authors proposed prescription of a brace be based on more objective radiological criteria and severity of low back pain. Brace prescription could depend on the flexibility of the curve and can range from accommodative to rigid braces of corrective design. Bracing adult scoliosis can complement physiotherapy and be an alternative to surgery. The brace should be systematically associated with PSSE. The so-called weak scientific evidence is related to the current limitation of research because it is necessary to perform clinical audits of consecutive series, including all treated patients. In most cases, a brace adapted to the patient physiopathology is available. Thank you for attention.
Thank you both for your review of the evidence, treatment goals, and indications. So as the questions are coming in, and please remember to ask your questions in the Q&A session. And if you like a question and you want to hear the answer to that, please give it an upvote so it'll bring it to the top of the question and answers. So as the questions are coming in, Fabio, let me start with you. And you commented on the Marty Perrant study describing type A and type B adult scoliosis. I'm curious how this affects your clinical decision-making. And so do you review this in the clinic with your patients? And if so, how does that knowledge influence your treatment plan?
Thank you very much, Jim. A very good question. So the main difference is that when you have degenerative scoliosis, they tend to be more aggressive and more easily symptomatic with respect to scoliosis idiopathic scoliosis that are worsening during adulthood. So you can expect to have some differences in the results of your treatment, but today I wouldn't say that there is really a different approach in terms of conservative treatment. The point is that you always share your decision with the patient, considering the advantages of bracing, the advantages and limits of bracing, the advantages and limits of exercises which are useful together with bracing, and you consider also the surgical option. You always discuss the surgical option with your patient. Then putting things together, considering also the age of patients and the risks of a surgical procedure, maybe you can decide to go for a bracing, even if it's not the ideal condition for such an attempt. So it's more about the decision of the patient than really the difference between idiopathic and degenerative scoliosis, even if we can expect probably, at least today, different results.
Okay, thank you very much. And Jean-Claude, a number of people are curious where you addressed 6 hours per day. Is that in sleep or waking hours in upright time?
You mean the wear time during the day?
Correct. So the question is, can you address the idea of 6 hours per day in sleep versus awake in upright time?
Oui. Alors, we begin, if possible, with a full time, 24 or 24, during 3 weeks. It's quite always possible. And then we write minimum 4 hours every day during the day, as I want. But statistically, when we control, the wearing time is 6 hours every day during 6 months. And then a little less, as I want, usually after sport activity or to prevent, to protect the spine during hard working. When we control 2 years after fitting the brace, half of patients don't wear the brace anymore. The other half, perhaps sometimes in case of pain, for instance, 1-2 hours every week when they work a lot. But the main treatment, we ask 6 months, minimum 4 hours every day.
Okay, thank you. The other question for both our speakers, so Fabio, if you want to begin, and then Jean-Claude, if you can answer as well. How does bone density affect decision for bracing the adult?
Well, actually, in a strange way. I mean, because if you have osteoporosis, you have a great contraindication for surgery. So this limits your options, and you have more need for a conservative approach. We started nighttime bracing in some cases of adults with scoliosis to avoid any impact on bones and eventually on muscles, because during the night you are already laying down, so it doesn't change from this side, and so you don't have any negative effect. We don't know if there's really a negative effect wearing the brace during the day, but we can suppose that there is some contraindication from this side. So this can be an option, but then it depends also on the clinical picture of the patient. If the patient is very, very stiff and bended, I think that they need to wear the brace also during the day. And I think to the oldest people, especially. If they are younger, you can think about some nighttime bracing. So osteoporosis for me, it's more connected to the contraindication of surgery, so limiting this option for these patients than preventing from bracing.
Thank you. Jean-Claude, any comment?
Yes, for us, it's a little different in France. The difference is that the health system is paying for adult bracing, corrective adult bracing. So it's easier for the patient to adjust to this type of brace. Usually, they went to us, they come to us to avoid surgery. This is the main indication. They want to wait a little for surgery because they know the level of complication. And they know also our protocol with 3 weeks at the beginning. And it's very easy. We limit some indications when it's not possible to correct the spine in the frontal and in the sagittal plane. There is a test we ask when they are laying on the examination table. It's necessary that the occiput is touching directly the examination table. Otherwise, it's impossible to correct, to make the brace in polyamide. Otherwise, it's always possible, and we test. And I am updating the results because the results I will present after were only for the first 60 patients. And now we have 150. And there is a very less dropout. Dropout is only 15% of patients, but they are motivated when they come to us to make the brace. They know the protocol and they want to wear the brace. So it's easier for compliance to make the brace.
Thank you. Yeah, another question for both of you. Do you still suggest corrective hard brace, meaning full-time bracing for young adults 18 to 21 years of age with curves around 50 degrees who refuse surgery?
Yes, in case they're willing to try to do something more, we do. We had some good results over the years. For sure, we can have an improvement of the aesthetic appearance, and not so sure you can have an improvement of the curve. So it's more for the aesthetics. Then it's an attempt from the side of the curve. But if the aim for them is to avoid surgery, why not to try?
Jean-Claude?
And at the beginning, the lion brace was very effective for scoliosis between 40 and 60 degrees due to the plaster cast. The limitation was the plaster cast. Some patients don't want the plaster cast. And no, I must say, it's the team of Milan who makes the proof that it was possible to avoid the plaster cast with, at the beginning, polycarbonate, but there is a problem of polyphenol intolerance. So this is why we use polyamide. With CAD-CAM and polyamide, it's like a plaster cast. So this is the explanation for the 3 weeks at the beginning to obtain a plastic deformation. And for this patient, it's quite possible to avoid surgery to stabilize. And also we note some improvement in the curve, probably due to this plastic deformation at the beginning. We have I can say 10, 12 degrees for this type of scoliosis, probably due to the lengthening of the concavity with full time. And I must say, it's also possible with a Schoener brace. If you have 50% of in-brace correction, and it's quite easy, even at 16 years, to have 50%, you can make the full time at the beginning and obtain this lengthening of the concavity, definitive lengthening of the concavity. This is, I think, very important. It's not only the Lion method, but it's this tensegrity, the lengthening of the ligament.
And can you both speak to the concept of utilization of bracing for protective purposes during more challenging motor activities to address the global deconditioning of many of the patients with adult scoliosis?
I'm not sure I understood the question. Can you say that again?
Sure. Let me find the question. Can you speak to the concept of utilization of bracing for protective purposes during more challenging motor activities to address the global deconditioning of many patients with chronic pain experience?
Okay, yeah, I usually suggest to my patients to use a little bit the brace during the day when they have to do something more stressful for the spine, like cooking for many people, like ironing, like standing for a longer time. So I think it's helpful to protect them from pain. I think that's useful for their quality of life, and then that's my only aim with this suggestion.
It's the same for us. There are two ways to protect. The first is during the total time at the beginning to found some compensation with the activity of daily living, because they must, they work usually. We don't stop working during the 3 weeks of total time. They drive the car, so they must develop some compensation. This is a way to protect. And the other way, it's a biomechanical concept of the name in French is composite beam. If you have a rigid plastic on the trunk, you have less pressure on the vertebra, on the disc, intervertebral disc, and on the spine. There is a diminution of the pressure. This was proved by Nakemson at the time, 40 years ago. It was possible to measure the pressure in the disc with a plaster cast. It was at this time with a plaster cast, but it's the same today with the rigid brace. And we have less, 30% less of pressure at the disc level with the rigid brace, the effect of the rigid brace. So this is really a physiological protection.
Well, thank you both very much. That concludes our Q&A session for the first part of our webinar. The speakers will do their best to answer any submitted questions that we were not able to get to. So thank you again to both Drs. Fabio Zana and Jean-Claude Demoreau for your lectures and insight. We will now move on to the next section of our webinar, Bracing for Adult Scoliosis. And for that, we will hear from 3 adult scoliosis bracing experts, Dr. Jean-Claude Demoreau, Dr. Jed McAvaney, and Stephanie Romano, and they will share with us their clinical approaches and decision-making process. Their talks will be followed by a panel discussion along with Dr. Zana, and we'll finish by asking your questions. So please continue to ask your questions in the Q&A session. Thank you.
The adult arm brace uses the new technologies of the Lion arm brace and responds to the constraints of brace effectiveness and tolerance. It was born from the observation that polyethylene braces did not correct the sagittal plane well. Moreover, lateral closure is sometimes difficult and the sternoclavicular support is very poorly tolerated. The corrective position is derived from the Lion 3D correction by coupled movements. The sagittal plane and the frontal plane are corrected simultaneously, taking care of the global balance of the spine. The spine is placed in maximum extension to promote lumbar lordosis and decrease thoracic hyperkyphosis. Since 2013, digital cast has replaced the traditional plaster cast. The advantages are multiple. First, the patient can maintain the maximum corrected position in the standing position for a few seconds. Second, breathing is controlled and the patient can be asked for maximum inspiration. Third, the accuracy of the aid sensor structure is less than 1 millimeter. Fourth, the 3 millimeter polyamide is with very high resistance can be used instead of polyethylene. The processing allows the realization of the positive with a minimum of correction at the scapular girdle. The CPO has all the tools to process and improve the scan. The main specifications of the adult heart brace can be summarized to make it as effective as possible. High resistance polyamide 6 with no abdominal compression. Short inguinal cuts facilitating the mobility of the hip. The wall is relatively discreet and aesthetic under the clothes. The rigidity of the brace is related to the thickness of the plastic. The increase in resistance us to decrease the rigidity for an identical mechanical solidity. That is why we use the 3 millimeter for adults. Transparency of the polyamide facilitates the balancing of the brace at the time of fitting by controlling the contact areas. Since 2013, the original corrective plaster cast has been replaced by correction directly on the patient. 1, 2, or 3 scans in the maximum tolerated alignment are necessary. During processing and CAD correction, no expansion zone. The brace is in total contact to avoid collapse in the brace. Since 2016, polyethylene has been substituted by polyamide 6. A comparative study between polyethylene and polyamide 6 is therefore possible. Group 1. From 2013 to the end of 2015, 55 adult lumbar or thoracolumbar scoliosis greater than 33 degrees were treated with a polyethylene bivalve brace. 29 patients were examined 2 years after brace fitting. For group 2, from 2016 to the end of 2018, 66 adult lumbar or thoracolumbar scoliosis greater than 22 degrees were treated with an adult heart brace. 40 patients were examined 2 years after brace application. In group 1 and in group 2, no statistical difference were noted for age, 65 years and 6 months, and initial Cobb angle of 50 degrees. On the other hand, there is a significant difference in brace correction from 18% in polyethylene to 29% in polyamide. The difference increases 2 years after fitting the brace with no correction for polyethylene and a final correction of 15% for polyamide. An independent sample t-test was conducted to compare in-brace correction and Cobb correction at 2 years without a brace. The percentage of in-brace correction had a statistically significant lower angulation for group 1 polyethylene than group 2 polyamide heart brace. The Cobb correction rate 2 years after fitting was statistically significantly lower for group 1 polyethylene than for group 2 polyamide heart brace. Non-parametric tests are also significant for percentage of in-brace correction and out-brace correction at 2 years follow-up. These results can be illustrated by 2 typical clinical cases. This 67-year-old patient had a very strong imbalance of the occipital axis of 40 centimeters to the right. The scoliosis T12L4 is 65 degrees. The first polyethylene brace redone 3 times in another hospital was not tolerated. A Walker device has been prescribed. In hard brace, the correction of the imbalance of the occipital axis in the frontal plane is significant. Similarly, in the sagittal plane, when the patient has difficulties to stand alone in brace, the trunk is much more balanced. Indeed, the in-brace angulation is reduced to 25 degrees with under EOS 3D, a refocusing along the vertical axis. The inclination of the rib cage to the right is clearly improved. The recentering at the lumbar level is linked to the translation with a horizontal iliac plateau that pushes as a caterpillar the lumbar vertebrae on the median line. Only polyamide allows a bending break of 120 degrees. The improvement is also clearly visible in the sagittal plane with C7 plumb line straightening. Given the difficulties of surgery, bracing is probably the only solution for camptocormia. The placement of the polyamide hard brace is performed by the patient who stabilizes the brace at the pelvis, then unrolls the spine using the rigidity of the posterior bar, and then blocks the upper and has a much better correction, even if the neck remains projected forward. Polyethylene does not correct the camptocormia. The polyamide of the hard brace significantly improves the posture that will be maintained and lines. This is why most patients keep their brace more than the recommended 4 hours a day.
As you know, we can't treat adult patients the same way that we treat adolescent patients. So the question is, how do we determine who is a good candidate for adult bracing? When we see adults, they often come to us with a chief complaint or a reason why they're seeking an adult scoliosis brace. This is often pain, a postural deviation, or progression of their scoliosis deformity that is faster than it has been previously. It's important to understand whether the patient was previously diagnosed as an adolescent or a child, or whether this is a new onset of symptoms that they never knew about before. We also want to evaluate what is the current treatment of their chief complaint. Have they pursued a scoliosis-specific therapy program, and did they get such as pain relief and postural improvement from those exercise programs? Or are they not a candidate for surgery at all? And have they had to decrease their activities of daily living because of the chief complaint? We look at the scoliosis brace as a means to bridge the gap in a patient's day. They start at the beginning of the day with therapy or exercises or a good night's rest, and they feel good. But over time, the posture and the ability to control their pain decreases over time. The patient feels like they can't get to the end of the day without having something to bridge the gap. This is where the adult scoliosis brace may be helpful for some patients. As we all know, it's important to determine whether a patient is a good candidate for a brace before offering it as a mode of treatment. We find that this criteria is not so much of a black and white or yes and no for bracing, but a scale of more likely or less likely that the patient will succeed and continue to use their adult scoliosis brace. The first is, does the patient do a scoliosis-specific exercise program and get pain and postural relief? If they're unable to do that type of therapy, or they don't get pain or posture relief with scoliosis-specific therapy, they're less likely to be a good candidate. Is the patient independent in their activities of daily living and have good hand strength? Patients who are not able to stand up independently from supine to standing, or they lack strength to don the brace or pull the straps independently, are less good candidates for scoliosis bracing. Patients who are motivated, they've exhausted their other treatment options. They feel like there's nowhere else to turn to try to get through their day, often have very good success and are very motivated to make the brace work for them. Patients who are less sure if they can accept a brace often reject it after a period of time. Finally, patients who are able to tolerate a simulated hand pressure of the brace during the clinical evaluation, and that simulated hand pressure causes pain and postural relief, often have the best success in bracing. Patients who are very sensitive to the touch, have pain with manipulation, or feel no change whatsoever with the simulated brace pressures, often are less likely to succeed in a brace. I wanted to show you two different patient types, one of which on the left has a flexible postural presentation, and the patient on the right has a more rigid postural presentation. These are two types of adult patients that we see, and we often base the brace based on whether they have this flexibility in their posture. We do look at the radiograph of the spine for each patient, but we find the Cobb angle, the magnitude, and even the location of the curve are not necessarily final indicators of whether the brace will be successful. Overall, the clinical evaluation is the number one, whether a patient can have good success in adult scoliosis brace. We see here, this patient on the left has a little bit of deviation of her hips to the left, arms collapsed into the concavity, shoulder asymmetry, but she is actively able to restore her posture to neutral by moving the hips and the torso into alignment and elongating her spine. With manual pressure of the hands, we can achieve additional elongation, which gives her great pain relief and lessening of her scoliosis symptoms. This is a great sign that the patient has some postural flexibility. The patient on the right has less or no postural flexibility, although her hips are also translated to the right or left, torso to the right, collapse in the shoulder into the concavity of her curve. Her hips and her torso do not translate. She cannot actively move her body into a neutral position, and hand positioning with no amount of pressure restores or changes this posture. It's rigid and inflexible. But this patient can get some movement of the spine in the axial plane, and when simulated elongation with the hands is put on the patient's body, she instantly feels pain relief. This can be another sign that a patient has the potential to have good success with an adult scoliosis brace. With the two different brace types, we use the amount of movement the patient has in their body to try to design that into the brace to hold and capture the amount of elongation and torso and pelvic translation that the patient's body can tolerate, and hold that while wearing the brace. For patients who do not have good translation between their torso and pelvis, we have a closed pelvis design with contact at the apex of the scoliosis and elongated trim lines to try to maintain that posture of pain relief. It's not a total contact brace. It simply supports the areas that need to be supported. Most of our adult patients wear their brace on average of 4 hours per day. They use it during activities that cause pain or after activities that lead to pain to relieve the chief complaint symptoms. We ask all of our patients to don the brace supine whenever possible because they receive the maximum elongation and are not attempting to fight and put the brace on against gravity. Finally, it's important for all adult patients to understand that adjustments should be expected to the brace. Our first goal is to design the brace with the maximum corrected posture that we believe the patient can tolerate. If the patient tries this brace a period of time, say a month, and is not tolerating the brace well, such as relief over flared ribs, relief over the apical prominences, sometimes trimming trim lines shorter than they were initially. If after that the patient still doesn't tolerate the brace, we look at compromising. What can we do to make this brace functional for the patient without compromising significant function and still make a brace that helps the patient reduce their pain, improve their posture, overall improving quality of life from the beginning of their day when they have a lot of energy to the end of the day where they feel like they can't get without something to help them in between. Thank you very much.
Hello and welcome. I'd like to thank SOSORT and the Education Committee for giving me the opportunity to speak with you today about bracing adults with scoliosis. My name is Jeb McNeil. These are my relevant disclosures, in particular to this presentation. I'm the CEO of Scolicare, which produces a particular. What I want to talk about today is the clinical application of adult scoliosis braces. In particular, I want to talk about the different influences that we have regarding prescription of scoliosis braces and some of the aspects of biomechanics unique to the adult spine, the type of brace that we prescribe, and also the protocol that we use for treatment with adults. When we think about adult scoliosis, it's really quite different in the majority of the cases compared to adolescent scoliosis. Some of the main biomechanical things that we're interested in is the stiffness of the spine. It can always be flexible, semi-flexible, or rigid. We could look at some of the imbalances, in particular the sagittal balance, but also the coronal balance. And particularly in degenerative adult scoliosis, we want to understand the level of stability or in particular instability. So we're looking for things such as lateral elastosis and spondyloelastosis. One of the best ways for us to really understand stiffness is through the use of bending x-rays. We can use some other techniques such as a scoliometer where we bend left and right, or scoliometer versus standing and sitting, but they're not particularly valid in terms of really understanding true flexibility. So still the bending x-ray is the best way for us to understand that. We know that stiffness of the spine in scoliosis is often age-related. In brace correction, we're likely to get. We're not always interested in brace correction of the coronal curve, but sometimes it is an important thing for us to see. In young adults, if the spine is flexible and there's good stability, we do know that there are some cases where partial improvement of posture, the cosmetics, and even the spinal alignment may be possible. We're going to go through some case examples to show how we go through the thinking of this process and how these braces differ in terms of some of their designs and how they work. So this is an example of a 20-year-old female. The curve is a thoracolumbar curve of 28 degrees. She has pain, particularly when seated. It's affecting her work. She's a drummer. As you can see, she's RISA 5. She has a relatively good overall global coronal balance, but regionally you can see that the thoracolumbar spine is offset to one side. When we have a look at her sagittal balance, her actual sagittal balance is not too bad. If anything, she has a slight posterior sagittal balance. She has a slight increase in the lumbar lordosis and a slight increase in the kyphosis. When she bends forward, she does have that rotation in the transverse plane. She is quite flexible, however, and here you can see she's doing an active self-correction on the right-hand side compared to what she's on the left-hand side. And in that active self-correction, we can see that she's able to manipulate her body posture and therefore the alignment of her spine. This is a really good sign if the goal of treatment for this young adult is to try and improve the regional coronal balance and to try and potentially even reduce some of the cosmetic aspect and maybe even to try and change a little bit of the curve. Here you can see as she goes through, she's quite flexible and able to do the active self-correction quite well. So in the brace, this patient uses a specific type of low profile Scully brace. We can see a nice brace correction. Now, in these younger adults, we give more of a full-time protocol. She's wearing this for 18 months, and she does a series of scoliosis-specific exercises using the ScoliBalance protocol. And after 6 months after she's been out of the brace, we can see significant reduction from 28 down to 17. Postural improvements, she no longer has any pain. So the bracing mechanics in this case of a young flexible adult really do resemble those of adolescent idiopathic scoliosis. So in this case, we see a case that the stiffness is flexible. The coronal and sagittal balance are pretty much within normal limits on a global aspect. And there really isn't any aspect of instability, no lateral elastosis or spondyloelastosis. The next really complicated factor is instability. We see instability either occurring at the onset of degenerative de novo scoliosis or as part of a degenerative process in previously stable adolescent scoliosis in the adult. We do know that the instability, particularly lateral elastosis, can be a source of pain with or without an alteration in coronal or sagittal balance. So this is a patient, we can see that she has a reasonably good global coronal balance. We do see some rotation in the Adams fork bending. Apologize for the quality of the x-rays, but you can see again, she has quite a nice coronal balance and quite a reasonable sagittal balance. If anything, it's slightly posterior. Here is the instability. This is just showing the 4 scans that we use for the patient. We take scans in multiple positions so that we can have an idea of flexibility, sometimes even without the bending x-rays. But here what we see is the evidence of the true instability. And you can see instability, seeing some osteophytic formation to try and stabilize that area. So in a case like this, where we have good coronal and sagittal balance, the patient presents with significant pain, we really do that the instability in this particular case is the cause of the pain. And the brace is focused on trying to really stabilize that unstable segment. To be able to do that, we'd like to see some change on the in-brace x-ray. This doesn't necessarily translate to an overall correction. However, in this case, we know that the main issue was degenerative instability. The pain was improved with bracing, and we saw stabilization of this curve over a 5-year period. Really, the bracing mechanics in this case are focused on stabilization of the instability. So in this case, we had semi-flexible. The patient had good coronal and sagittal balance, but the underlying cause to their pain and discomfort was that instability or the lateral elastosis. The other aspect that's heavily researched in adult scoliosis is imbalance. In particular, large alterations in sagittal balance are linked to pain, disability, and curve progression. When the spine is also stiff, this represents a unique challenge for bracing biomechanics and really requires a focus on elongation and a restoration of normal sagittal balance if possible in the brace. Here we can see an elderly patient. This patient is in her 90s, and she has on the right-hand side, you can see quite a significant anterior sagittal balance. You can see that she also has quite a significant coronal imbalance. When she bends forward, again, we have that positive rotation in the transverse plane. Looking at the numbers, we can see quite a significant anterior sagittal balance on the right. We can see a loss of the lumbar lordosis, even forming a little bit of a lumbar kyphosis, and quite a significant left coronal balance. This is a different type of brace design. It requires a higher style of brace so that we have longer lever arms to control the patient in the sagittal spine. Little video just showing that even in these old patients, we can get quite significant changes in their standing balance as well as their physical balance. And it's not necessarily that difficult for these patients to use this style of brace. So you can see this patient on the very first day of the brace fitting. She's able to stand up, walk around, and tolerate the brace quite well. So this patient demonstrates that even in a 94-year-old, we can get good clinical outcomes. The thing that we're most interested in this case is particularly the sagittal balance. If you look on the right-hand side, you can see quite a nice change from her standing in a neutral posture to her embrace posture. She's now been going through this treatment for over 6 years. She's 102 years of age, and she's doing quite well with treatment. So this shows that this is a case that's somewhat rigid in the spine, although the posture has some flexibility to allow her body to rebalance. She had alterations in both coronal and sagittal balance. There wasn't a huge amount of instability. We didn't see large lateral or spondylolisthesis. Then obviously the hardest cases that we face in adult scoliosis are the complicated cases where we have a little bit of everything. This is a case of adolescent scoliosis in the adult that has now undergone a degenerative phase. This patient had scoliosis as a teenager. This scoliosis has progressed later on in life and has also developed some degenerative instability. We can see quite a significant deformity in the transverse plane on full bending, but quite notably, her disability and pain really started as she developed that anterior sagittal balance that we see here on the right. When we look at the anterior sagittal balance, it's well outside of normal limits, 11 centimeters forward. We can see that she has quite a significant curve of 56 degrees, and she certainly has that lateral listhesis of L3 on L4. In the brace, however, we can see quite significant changes in the sagittal balance. We can also see changes in the coronal balance. With the X-ray, we'll actually see that not only do we have a change in that, but in brace, there is a reduction of the curve. Again, we're not likely to see long-term reduction outside of the brace, but it does show that the brace is changing the loading mechanics of her spine, which should in turn have some effect on her pain. We can see that the sagittal imbalance is reduced by at least half. And if we take a close look, we can see that even that lateral listhesis has reduced a little bit in the brace. So this is showing that adult bracing, even in some of these more complicated cases where the spine is rigid, where we have alterations in both coronal and sagittal balance, where there's even a lateral listhesis, can sometimes still be well controlled with bracing in terms of the patient's pain and disability, allowing them to have a better quality of life. In summary, there is a growing evidence for the use of bracing in adult scoliosis. The treatment approaches and goals vary depending on the patient's age and unique features of their scoliosis. If it's in the patient's best interest, then bracing can be offered as a treatment so long as the limitations of the interventions are really well understood. And more research is required to determine what bracing approaches are most appropriate for different types of adult scoliosis presentations. Again, I'd like to thank SOSORT and in particular Sonia Schreiber from the Education Committee for inviting me to give this lecture, and I look forward to any questions that you may have. Thank you.
Well, thank you very much to all of our panelists for presenting. I'll ask all our panelists to please now turn on your cameras and your microphones, and Dr. Fabio Zana to join the panelists as well. And while they're doing that, and please begin to type your questions in the Q&A session, and we will address those. So I'd like all the panelists to begin the conversation, if we could begin a discussion on what is your best advice to develop a truly multidisciplinary team approach in adult care? And after that, I'm curious too to hear from the physicians what you want the orthotist to know or think about when designing a brace. And then from the orthotist, what do you need to know from the physicians and the physical therapists so that you're thinking about the most appropriate brace design? So if we begin that, and Jeb, why don't you begin the conversation?
I think it's really important to have very good communication, ideally to have a clinical team meeting on a regular basis so that everyone can be across what the goals are, because with adult scoliosis, really the outcome that we're after is more related to the patient's goal. So you might have patients that, you know, start off with PSSE and they're struggling with that. They might be stiff, and therefore you've got that feedback from the therapist saying that, you know, this is a patient that's really stiff, they're struggling with the therapy, so that when you go to design a brace, you know that you're probably going to run into problems if you make that brace too aggressive. And, you know, the correction isn't necessarily the goal in some of those cases. The goal is potentially pain relief. So having everyone clinically on the same page, I think that, you know, that communication about those specific cases is really important.
And Stephanie, your thoughts?
I agree as well. In terms of speaking, I find that many of the times, so many of the people that we're working with we're still in the stage where we're unsure about adult scoliosis bracing. So it's really good to talk about the goals and what do we really want to achieve. And like Jeb said, most of it revolves around helping achieve the patient's goal for what they want for their life, their chief complaint. And so we're revolving around this, especially working with the therapist when they're present to talk about what the patient is struggling with. Same thing, I really just echo what Jeb said in terms of collaboration, because I think that's true in all these cases.
And Jean-Claude and Fabio, from the physician's point of view?
Yes, for us, it's evident because the correction is done by the physiotherapist. I make the physiotherapist sometimes, you have seen on the video, but it's the physiotherapist who makes the correction and the CPO take the scan. And after there is a work with the software to combine one or two scan and to make the positive, to make the brace. But the correction must be done by the physiotherapist who know exactly what is the possibility, the best possibility for the patient.
Thank you. And Fabio?
For our team, we have shared protocols with physios, and it's quite easy to work with them since we worked on exercises for adults for more than 20 years, so it's quite easy. More challenging today with the orthotist because we are changing the way we are building braces for adults. We were used to make more aggressive braces. Now we are changing, following what Jeb was saying, especially. And this shift needs a deeper discussion and collaboration on each single case with our orthotist. So we are working on each single patient with the orthotist, and we are trying to think about the best possible design for each single patient. But we learn together, we and the orthotist, we learn together, working together on the patients, making mistakes also. And sometimes you make a brace and you think, oh, I should have chosen another design. This is not the best, but sometimes you really discover it after you fit the patient. I think you know very well, all of you in the panel know very well this issue.
Yeah, and I think to follow up on that, it's a good point. One question that came up were, what are the contraindications for bracing? And as you all have experience with this, and as you mentioned, Fabio, sometimes you don't have the right design. And Stephanie, you mentioned in your talk that you modify the design some way. What are the conversations that you have with the patient when you really don't think the bracing is going to be appropriate for them? Stephanie, maybe you can begin that conversation.
Well, I tell my patients, you're going to give up on me before I give up on you. So I will adjust their adult scoliosis brace as many times as they are willing to come back. If it requires a redo, I will redo it. If there's an identifiable way that I can fix or improve something that's happening. There's a lot of unique creativity in adult adjustments, in rearranging pieces and parts. It's hard to say generally what those are without looking at specific cases, but I just keep working on it as long as they're willing to pursue it. And I actually find that some adults will say, I can't do this right now, and put it aside, and then come back 6 months later or a year later, and they'll say, I would like to try this again. And we have success the second time because they've gotten to that place mentally where they say, actually, that was the best thing that helped me at the time, but I wasn't willing to accept it in my life. And so we're not just battling a position or a cob angle, we're battling a lifestyle change that not many adults really want to have. Most adults don't come saying, yay, I really want a rigid brace, but they're willing to accept it if it's improving some aspect of their life that they're having other challenges and no other way to solve that problem.
Very good, thank you. Jeb, any comments?
Yeah, I think one of the biggest, I don't know if you'd necessarily class it as a contraindication, but perhaps one of the biggest issues is patient expectation. That you have patients coming in with scoliosis, they see the coronal plane curvature, they don't like the way that they look and they feel, and even though they're older and their spine is stiff, they still sometimes have an unrealistic expectation that their spine will achieve a correction. And I think that, you know, if you don't address that expectation from the outset, then, you know, you'll often have unhappy patients, because that's not necessarily the goal with adult bracing. The main goal should be, you know, changes in global balance, sagittal coronal balance, improvements of quality of life, and those things. So I really think that setting that expectation from the outset is really one of the most important things.
And Fabio, any comment?
Well, I think that a possible contraindication is to have a patient passively supported for many hours, for too many hours during the day, for a long time. That could be an issue. All but that, I don't think there are other issues with bracing in adults. I was in a course yesterday, and there was a surgeon commenting with us a clinical case, and he was saying that you should always try with the brace. If you have good results, that's perfect for the patient. If you don't, they can think about surgery if there is an indication. So why not to try? It's important then, as Jeff said, to set the expectation of the patient. That's very important. And for me, the challenge today is not just about the design, but also the protocols. Who, when, how many hours, nighttime, full time, only the day. I was very interested by Jean-Claude saying that he has this protocol with this full time at the beginning. Never heard about that in adults, so it's really interesting to me also. It becomes a further option for patients to study. So I think we are at the beginning of the journey, and we must be very open-minded to try to do the best for our patients with this important, potentially important problem for their quality of life.
Jean-Claude?
Yes, for us, the reducibility is a contraindication. When it's not possible to realign the sagittal and the frontal plane, we don't make the brace. I remember one patient, they don't touch the head with the examination table. I say, no, it's not possible to build the brace. So she was working with her physiotherapist during 6 months, and she come again 6 months after saying, doctor, yes, I touch the table, you can make the brace. So this is the only contraindication. I must say that we don't have a lot of modification on the brace, because the brace is made directly on the patient. This is, I think, the secret to have a good brace, the correction done directly on the patient. And you have seen the patient sometimes make himself some modification. The camptocormia, you have seen that he was introducing some pads on the metal bar to protect the spinous process. He does this. We don't do nothing. So the patient make sometimes some modification, but usually for the orthotist there is nothing to change, and psychologically the brace is the delivery of the brace is Friday, for instance. Monday, the patient has the EOS X-ray with a correction. So he see that the brace is working. So psychologically, it's very important for the tolerance. When he sees X-ray, initial X-ray and in X-ray under the brace, in brace X-ray. And the full time, as I say, is a very good solution to make an anesthesia under the skin. It's like the watch. When there is a total contact, it's no problem. And for Fabio, there was a plaster cast before the French polyethylene brace. And they do this also Palazzolo, Marti, Pumra. There was a recovery of sometimes 1 month with a plaster cast to give the correction before the polyethylene brace.
Yeah, if I can comment, yeah, also Sibilla here in Italy used to
Yes,
make.
yes.
I know. We moved a bit from that concept, and we tried to do something different. Again, these are very good ideas for me that I need to elaborate. And happy to know more about your experience. Thank you.
Yeah, I think it's a wonderful opportunity, as you've mentioned before, for some research and some collaborative research as well, as to, right, as we're all on this journey with adult scoliosis. So we're now going to switch and start asking some questions for our attendees. So I appreciate and I want to thank everyone for submitting the questions and for clicking on the questions that you want answers for. So please continue to write your questions in the Q&A area. So the first question, given the unique presentation of each patient, is custom bracing more appropriate than some off-the-shelf or what might be considered custom fitted devices? So if you can please comment maybe on your experience between the two, and then how do you delineate? When do you decide to go custom and when do you think off-the-shelf is most appropriate? So Jeb, maybe if you want to start.
I think that might be a question that Fabio would answer a little better. We generally don't use many off-the-shelf braces for adult scoliosis. There'd be a few exceptions, if the patient has, very minimal scoliosis with sort of low back pain and, there's not really a need. And then, we occasionally would use something generic. But in the majority of the cases, we've found that to effectively control, particularly the sagittal balance, and also when you've got a lateral listhesis or instability, we prefer to use a custom style brace.
Fabio, some comment?
So today for me, it's more, the choice is more connected to the general strategy. If I want a nighttime brace, for sure, it's a custom-made one. If I have and usually is a bit younger patient, 50, 55, up to 65, something like this of age, years of age. If I want the brace to be used during the day, there is a new brace called BJM1, which is very promising. It's off the shelf and it's very promising with a good support under the armpits and the big push that can be remodeled over the patient on the back. And this is something really new. It's on the market, but not enough data today. So that's why I'm speaking about working also on the protocols and not just on the brace, because for me it's together. According to the protocol, I choose the brace. It's not just the way I build the brace.
Jean-Claude?
I don't make a lot of prescription for soft braces, but I am not against. And but usually in France, it's medical doctor of the patient who are prescribing this type of braces. And sometimes it works on the pain, especially on pain. And they come to me after if there is progression of scoliosis or pain again, more pain. I am not against, but my practice is concentrated on rigid braces. So this is the way I use a lot of rigid braces. Yes.
Okay. And Stephanie, what's been your experience?
We have the same answer. We primarily only do custom adult scoliosis bracing. And where I work specifically, we work with a team of therapy offices, and oftentimes they have a generic soft brace with a rigid panel, and they try that there with the therapist. And if that's something that seems like it's relieving symptoms, they will do that. However, as the orthotist, I have not been using adult prefabricated scoliosis braces. But I do want to say, we talk about complexity of these adults. I find that it is hard without a measure of experience to train people who haven't treated adults, or maybe less experienced practitioners, what to look for. And as Dr. Zaina mentioned, there's not really a protocol yet of what to check. It's almost that you get the experience and you learn what works and what doesn't. And when you make mistakes, you say, oh, I don't want to make that mistake again. And so some of this is a measure of experience and distilling it down to what is a good protocol for who's good and not. But I don't know that we're there yet to know for sure. We're still trying to figure out what exactly makes the adult brace work for some and not for others.
Thank you. Another question for the group. Could you please clarify how the adult bracing acts on the soft tissue? Jean-Claude, do you want to begin that?
This is the plastic deformation, the creep. If you maintain the correction on the concavity, usually on the concavity, 3 weeks, it's like club foot. You know the Ponseti with only 3 weeks. A new plaster cast to correct club foot is it's a little the same. If you maintain the tension, you have a real effect on the fascia along the spine, on the concavity, and you can. This is why we have some 15 degrees correction for scoliosis after the end of course. We work on this soft tissue. It's also very important in the sagittal plane. If I can do a take-home message, for adults, the more important is the sagittal plane. And if you are able to maintain lordosis and kyphosis, the frontal plane is not so important. I think also with the metal bar, you can use polyethylene because in the frontal plane, it's not the problem. And the second point is the lumbosacral scoliosis, the tilt of L4. This is very important. Jeb and Stephanie, you show patients with imbalance on the convexity, with a very important tilt of L4. And for these patients, adult patients, we found that the secret is the iliac plateau, to push the L3 on the medial line, not to try to correct scoliosis. If you correct the lumbar scoliosis, you increase the imbalance. So this is very important. Two points: sagittal plane and this we can say tilt of L4, the lumbosacral scoliosis. And for this, you need a good support on the pelvis to make this iliac plateau on the brace. You can do this with polyethylene. It's not a problem. But it's really a particular concept, an anomaly of the iliosacral basis. It's oblique. L4 is oblique, and automatically there is a curve, but a secondary lumbar curve. The problem is at the lumbosacral junction, and the brace must treat this lumbosacral scoliosis.
Thank you. And Jeb, I'm going to move to another question. So Jeb, you had mentioned using bending films to assess flexibility. I know not all of us have access to bending films, and there's some concern about the radiation exposure with doing full cassettes on films. And you mentioned sitting versus scoliometer reading. Stephanie, you had mentioned about using your hands to mimic the corrected position and kind of understanding the flexibility factor. So the questions come in, is there a flexibility, how do you score flexibility? So I'm curious, I think we have a pretty good understanding of flexible, we have a good understanding of rigid, but how do we score that semi-flexible, and how does that influence your design features? So Stephanie, maybe you can start that discussion.
I think that we need a better way to objectively score flexibility. And that is one of the frustrations that I have in teaching other orthotists, is that the evaluation that we're currently doing is very subjective. It is not objective. And it requires some experience in seeing multiple adult patients to really understand. And I would like to work more on having more objective measures for adults so we can create a better protocol for who works and who doesn't. But I don't have really an objective way to measure flexibility.
And Jeb?
I think it's an interesting question. I don't know that an objective score of flexibility is necessarily that useful to the brace design. Like, we know that systemic scores of body flexibility don't necessarily relate, for example, to spinal flexibility. And the spinal flexibility, the bending films are the gold standard, but again, that doesn't necessarily translate into the correction that you want to achieve for the patient. So I think it's more a clinical way of understanding flexibility, much like Jean-Claude does, where he has the physiotherapist put the patient into the correction. One of the issues we find with that is that in multiple clinics, that somewhat comes down to the skill of the physical therapist and the team, and there can be some variations in that. So we use a slightly different approach by taking multiple scans in elongation, scans prone, scans supine, and then comparing those to the neutral scan. And then the combination of those scans gives us a little bit more objective information about how the spine moves in those loaded and unloaded positions. And then essentially based on that, we use that information to determine how aggressively we make the brace. I think in the future, with lots of data and machine learning and that type of thing, we can probably use that scanning data to be able to come up with something. But for right now, I don't know that we really have a good scoring system that we're going to be able to apply at this point in time.
Okay. Fabio, Jean-Claude, any quick comments? We're coming to the end of the webinar. Flexibility scale.
We use bending only for surgery. It's a clinical correction of the patient, bending only for surgery.
I don't think we need bending for adults, because if it's enough to support the spine. The goal is really not to correct. If they are flexible, you can push a bit more. If they are not, you just keep them, and I think it works enough. So it's different from kids.
I would add, Jim, you had asked earlier what orthotists need from physicians. Is we need to make sure we have lateral views of the spine, because many adults come to us with no lateral view and are resistant to get new x-rays. And I think orthotists need to realize that we need to push for those and not treat with a one-sided view of a three-dimensional deformity. And that's becoming more and more evident, especially with adults, but probably also with adolescents as well.
Yeah, I think that's an excellent point. And with the advent of many more EOS and low dose radiation, we're starting to see more laterals, but you're right, we're not getting them at the rate that we should be to really assess the spine in 3 planes. So, well, thank you all very much. I really want to appreciate and thank all our panelists for your expertise and sharing and the time you put into preparing your presentations. It's what SOSORT's all about. And thank you to everyone who participated and all those who joined. Special thanks to all of you, our speakers, to Sonia and Tony for all the work you did behind the scenes, Sonia for organizing this. These events don't happen without your dedication and work. So congratulations and thank you all. I would ask you all to please think of joining us on November 5th of this year for a SOSORT SRS collaborative webinar entitled New Horizons in the Non-Operative Care of Children and Adults with Scoliosis, Expanding the Use of Bracing in PSSE. And you can go to the SOSORT website for more information. Also consider conducting a fundraiser or donating to SOSORT. Unicyclist Rory McInerney completed a fundraising unicycle ride around Port Phillip Bay in Australia, raising approximately 5,000 Australian dollars for SOSORT in an effort to raise awareness on scoliosis. So you can find his story at Facebook/Roy Rides the Road. And we hope to see Roy at the SOSORT 2023 meeting and thank him in person for his efforts. So to all members, please make sure that your dues is up to date. And to all attendees today, please think about submitting your abstract and plan on attending SOSORT 2023 in Melbourne, Australia. That's May 1st to the 5th. And we hope to see you all there. Thank you all very much. Be well.